Welcome to Policy, Not Politics. Our guest today is Senator Steve Dickerson, the state senator representing Nashville, Tennessee, a Republican state senator representing Nashville, kind of an unusual
I'm the one and only.
one of the token Republicans representing Nashville. And you are, for the, I think, fifth year in a row,
Correct.
co-sponsor and lead Senate sponsor of a bill to legalize medical marijuana. And you tweak the bill a little bit each year, and you
Correct.
have again this year. Your bill includes expanded medical research and with treatment options that utilize cannabis and cannabis extracts under medical supervision. I took that right off your news release. Would that research have to be concluded before the doctors can begin prescribing, or would the two happen simultaneously?
Great question, simultaneously. And so as far as the research goes, one of our contentions is that people who use cannabis-based products, if they're properly diagnosed, properly prescribed, will actually have improving health and maybe decrease utilization of medications like opiates. And so one of the things that is part of this bill is sort of a longitudinal tracking of people's health. And they can fill out a questionnaire as one of the possibilities, and just reply, here's how I'm feeling, my pain is improving, the number of Percocet I'm using per day is decreasing. And so it's not research in the sense that it's a double-blind prospective study like you might read in a journal, but it's really just sort of a data gathering for us to track patients and sort of reassure ourselves as legislators and as administrators that, in fact, we're accomplishing what we set out to accomplish.
That kind of research allowed by the federal government, because I know that was once upon a time, if not still, a problem. That would be against government law.
So
government.
So the federal government does complicate things dramatically. Cannabis is still in its raw form. Marijuana is still a Schedule I substance, and that is the federal government does not recognize any legitimate medical benefit. Now the irony of that is the two big constituents, which are CBD and THC, are both recognized by the FDA as having medical benefit. The parent compound is not. As a result, there's been very limited medical research in the United States that has taken place. What we'd love to see is a major medical center like Vanderbilt, ETSU, University of Tennessee, allowed to take cannabis and try it in any number of conditions, things like neuropathy being a great example, and engage in prospective, double-blind, randomized, placebo-controlled studies, which are sort of the gold standard. Have a group of patients that has placebo, group of patients that has the medicine. They don't know which, and then you track their symptoms over time. That's not currently allowed. So what we've done is sort of done the best we can, which is track patient symptoms on an ongoing basis. We do not think the federal government will interfere with this at all. There was some question under the Obama administration. They chose not to enforce cannabis laws or prohibitions against medical cannabis patients in states that had legalized it. The Trump administration backed away from that, but now they've sort of moved back into the same posture. So we don't really anticipate a problem with that at all.
Okay.
This will not be studies, however, that include our medical centers. They still are arm's length on this.
Would they be state or federal funded studies, or
this would be only state? And again, to call it a state,
there would be state funding for the studies?
Correct, and it wouldn't cost much. This actually would be very simple to do. Again, it's just tracking patients on a day-to-day, week-to-week, month-to-month basis. And we would obviously anonymize that, so when this data came in front of the commission, they wouldn't say, John Jones is having worse symptoms or better symptoms. This would be, of the 1,000 patients who have neuropathy, 80% of them are improving.
Right. You're a pain doctor in layman's terms.
Correct.
You envision it to be used for pain management. You know more about pain management than anything else, I would think. And you think it may reduce the demand for opioids for pain management. Could you elaborate, how does marijuana, or how might marijuana affect pain?
Sure. So to put it sort of in broad terms, pain is not just simply one system in the body. It's not one chemical reaction, but in fact it's multiple. And I would say 5 or 6, but it's probably 50 or 60. But there are many, many different spots in that pain chain, if you will, that you could try to block it. And the medical term for this is multimodal therapy. So I'll give you an example. If you have pain, if you go get your gallbladder taken out, or if you break your leg, I could give you enough morphine that you'd stop hurting at some point. Maybe it's a milligram, maybe it's 10, maybe it's 50. Right. As you increase the dose, you see side effects get worse. Things like drowsiness, constipation, all sorts of problems. You actually, in high doses, you can suffocate from too much narcotic. The current theory, and I think there's really good basis for this, is instead of giving a lot of one medication, give smaller doses of multiple medications. So if you're a patient with rheumatoid arthritis or one of the inflammatory bowel diseases, what we might do is give you a little bit of a non-steroidal, something as simple as ibuprofen, give you a little bit of cannabis, and maybe give you a little bit of another medication or two. So you keep the overall dose of any individual medicine lower, but you can actually see lower side effects and better results with this. So I see cannabis as fitting into that sort of paradigm.
Sounds like you might be talking about prescribing both opioids and cannabis at the same time, but in lower doses of each.
So it would be a very patient-specific decision, obviously case-by-case basis. And just to make sure our nomenclature is correct, we wouldn't be prescribing cannabis, and that is a tip of the hat to the federal government. As a physician in Tennessee, what we would do is only affirm that you have a certain condition, and it may be neuropathy, could be Crohn's disease, could be a seizure disorder. All we as physicians would do to stay from going afoul of the federal government is check, yes, John Jones, I keep saying that, John Jones has Crohn's disease, and then they would take that form to the pharmacy, and it would be filled at actually the dispensary. But to get to really the root of your question, I think it is a patient.
It is possible that you could be prescribing opioids in smaller doses and check the box that allowed them to go to the dispensary and get marijuana.
Correct.
Okay.
But to go back to your first question, though, about the data and the studies, what we would then do is make sure that those patients in the aggregate, the 1,000 or 5 or 10,000 patients, actually are using lower doses of the other medications.
Okay. Well, when and how did you become convinced that marijuana has some pain management?
Right. So I would call it cannabis. Just that's a branding issue, but we're trying to destigmatize it here. So in my experience, I'm board certified in anesthesiology and chronic pain management, and treating chronic pain patients. As clear as I can remember anything, I would have 2 groups of women come to my office, typically in their 70s or 80s, and they would have terrible spinal issues, and scoliosis is the one that people have heard of, and that's sort of the root of the problem. And I had these women time after time, and half of them would come in and say, well, I'm taking a little medicine, and I'd really like to garden or play bridge or do my dishes or what have you. But if I take too much medicine, I start to get constipated or drowsy, and it's not really working. But my grandson, he said that I should try cannabis, and so whether smokable or put it in a food, she said it's unbelievable. My life's been restored. It's fantastic. Then I had a second set that said, my grandson wanted me to try some, but if Governor Haslam or the president at the time, President Obama, wanted me to try cannabis, they'd make it legal. So I'm not going to do it. And they literally divided themselves into 2 groups. And when I saw, pardon me, the difference in their quality of life, it convinced me that there was benefit. And so that's really what interested me.
What do you say to the people who say, well, that's just because the cannabis gives you a feeling of euphoria, so you may have as much pain, you just don't mind it as much.
Right. So I can't really argue that point. But I would say in the patient population that we're talking about, and these are some of the sickest people in Tennessee, if the alternative is to take an opiate as one choice, which has side effects, option number 2 is to suffer, or option number 3 is to blend some cannabis into their treatment, plan. I'm all for option number 3.
Okay. Did the bill specify the allowable uses? Will it include uses for mental health issues such as depression and PTSD?
The answer is yes, but that's a moving target in our terms. So here's the trick. We want to make sure that what we do is not too expansive, and we don't want to say just because you're anxious you can go and qualify for this, because then we'd see a lot of people that might claim to be anxious. We want to make sure that the illness is that there are enough data out there that we feel comfortable enumerating probably 10 or 15 diseases to start with. But the key point is to empower the Medical Cannabis Commission that's going to result from this bill to add or subtract conditions on an ongoing basis as the data improves over time.
So before the target starts to move, what does it allow initially?
Great question. And I don't have the bill in front of me.
But are there a lot of different things, or are they very
they're about 10.
About 10
Yeah,
different
about
things.
10.
Is depression and PTSD among them?
I believe PTSD is. I actually don't recall if depression is or not.
Okay, but pain management would be.
Yep.
Okay.
And things like inflammatory bowel diseases, neuropathy, chemotherapy,
Glaucoma.
I think glaucoma it's been on one version, and so there are two bills out there, and I'm the Senate sponsor of one of the two bills, and so really we have 4 people that are working on this. So that
the reason that I wanted to talk with you is because the House Speaker told me personally that the only bill that he would support, possibly, and he's still undecided, would be Dr. Terry's your House colleague on this. So it's your bill that has at least a chance of passage.
It does, but I also am really working hard with the other sponsors. Senator Bowling is my colleague in the Senate in trying to find. So I'll tell you this: I've done this 5 times. My bill is much better than it was, but I would not tell you that my bill is perfect. Any major bill like this, and it's over 70 pages. Can always be improved. There's something that can always be tinkered with. And so I've worked with Senator Bowling and actually taken some of her bill and folded it into mine because I think she frankly had some better ideas in some ways.
Will any doctor or psychiatrist, a psychiatrist is a doctor, be able to check the boxes, or will it be only certain specialties that can do that?
We anticipate that any physician would be able to do that.
Your family physician would be able to do that. You wouldn't have to go to another.
Not to a specialist.
And how long a period of time? A lot of prescriptions make you come back in a year to get that prescription renewed. Is that going to be the same sort of timetable that people would?
What I would anticipate is probably a 12-month, and this is really an affirmation that you have a condition. And then you'd go to one of the dispensaries, and we have a pharmacist there who will do some continuing education and be, if not an expert, at least well-versed in cannabis and its role in healthcare.